Hi, good afternoon, everybody. Thanks so much for joining us. I know that the main session and the presidential talk is still going on, so hopefully more people will trickle in as we go. Don't take it as a lack of interest in Dr. Shu, who is my excellent colleague here from Columbia, who's going to really, I think, hopefully shed some light on bringing precision lung cancer care to the perioperative space, how to maximize the impact of EGFR-targeted therapy for resectable non-small cell lung cancer. So as I said, I'm here with Kathy Shu. She's an associate professor of medicine and the director of thoracic medical oncology at Columbia in New York. I'm Brendan Stiles. I'm a thoracic surgeon at Montefiore Einstein in New York. And so just a couple of housekeeping details. This is available virtually as well, but thanks to all of you in person, everybody grab some food and make it casual. PeerView is thanks to PeerView for providing for the session and to AZ for providing the independent educational grant to support the symposium. If you haven't already, please fill out the pre-event survey that's on the iPads situated around the room. Look out for additional audience polling questions during the presentation. We really want this to be interactive and engaging. You can also ask questions through the iPads, but also encourage people to come to the mics if you have any comments. Here's the website information, which will be included and sent to you. So the goals today, in today's session, we're going to leverage some case reviews and bring contextual discussions of the relevant data to highlight the importance of conducting biomarker testing to identify patients with resectable non-small cell lung cancer with EGFR mutations. We're going to talk a little bit, or actually in depth, about the evolving evidence supporting the use of EGFR-targeted therapy in resectable non-small cell lung cancer, and talk about some of the updates that are on the horizon. We'll engage in best practices for multidisciplinary collaboration to integrate EGFR-targeted therapy into treatment plans for appropriately selected patients. So I'm going to turn over to Dr. Shu, who's going to take us through a case.
Thank you, Dr. Stiles. Thanks, everyone, for having me here. My main COI today is that I'm a medical oncologist, so thank you all for having me speak here at your nice conference here. So I'm going to start briefly with a case. We're not going to go through in detail, but we're going to come back to this case afterwards. So she's a patient of mine, a 64-year-old woman. She was a never smoker. She first presented with COVID-19, and her chest CT showed a 3.4 centimeter left upper lobe mass. We got a PET scan, which showed that it was indeed hot, SUV of 5.3. The pleural looked normal. There was no mediastinal or hilar lymph nodes, no sign of distant disease. An EBIS was performed and did not reveal any suspicious nodes. And a transbronchial biopsy of this mass showed invasive lung adenocarcinoma. So these are the polling questions, and we'll kind of review these again at the end. But for now, at the beginning, what would you recommend for this patient? Would you, 1, take her to the OR for resection, 2, refer her to medical oncology to discuss neoadjuvant treatment, 3, send her for molecular testing, or 4, I am not sure? Okay, so I am speaking to a room full of surgeons.
Yes.
Let's all take her to the OR. So now a little wrinkle. The NGS panel reveals an EGFR exon 19 deletion. We're going to ask you the same question again. Knowing this, does this change anything? Do you want to, 1, take her to the OR, 2, refer her to medical oncology, or 3, I am not sure? Oh, whoops, I couldn't see the results. Oh, okay. Oh, half the people now want to send her to see someone like me, while the other half are going to take her straight to the OR. Okay, so actually, she is taken directly to the OR, and she had a left VATS upper lobe. It revealed a 4.4 centimeter invasive adeno, moderately differentiated. extending into visceral pleura, and multiple lymph nodes were involved, including 2 level 5, 1 level 7, and 2 bronchial. So she was staged as a PT2B-N2. And what do you want to do now? So there are a bevy of answers here. Adjuvant chemo, refer her to radiation oncology for post-op RT. Osimertinib for 3 years, atezolizumab for a year, observation, or I'm not sure, this is why I will send her to MED-ONC. So those are your options. All right, so a 44% said adjuvant chemo. Oh, sorry, how do I go back? For some reason it didn't.
There's no going back.
All right, well, some of you said adjuvant chemo. There we go. 44% said adjuvant chemo, 33% said OC for 3 years, about 10% said atezo for a year, and no one wants to do post-op RT anymore. So,
Thankfully.
with that, we are going to start our program. We will come back and talk about this case, and we'll see if any of your answers change, and we'll review some of the data.
Awesome, thanks, Dr. Shu. That was a tough one, right, because there wasn't chemo and OC, I was thinking, so it'll be interesting to see how we do that.
There is not necessarily a correct answer in there, and we'll talk
Exactly,
about
right.
it. There could be many right answers.
So let's talk about EGFR mutations. And the rates and prevalence obviously depend on where you are, obviously, in the world. But generally, across different stages of non-small cell lung cancer, and these are US-type patients, stage 1, 20%, stage 2, 18%, 3, 18%, 4, 26%. But I think the message here is that it's really consistent across stages. And so this is a high proportion of our patients that we have to think about, and increasingly we're going to have to think about them as we manage them through the whole space, from diagnosis to preoperative treatment to adjuvant treatment. But there's gaps in biomarker testing. Many of you are probably aware of this, right? And we didn't really have to think about this in the surgical side, but the medical oncologists have been thinking about this for a while, where it seems so obvious because they wait to start treatment until they get the molecular testing back. But you see that frequently that testing is not done. And it's not done on an NGS pattern or a platform typically, but often even, and I forget if this slide has it, that even when it's done, sometimes patients aren't often treated to the actual testing. But particularly relevant to this talk, you see that rates of EGFR testing at these time periods from 2018 to 2020 still sort of hover around the high 70 benchmark. So even in the stage 4 setting, we're not getting to the types of biomarker testing that we think that we need. This is compounded by the problem in the adjuvant space. So biomarker testing for us, if we have the process in place, should be relatively easy, right? We've taken out the whole tumor. We don't have to worry about the tissue acquisition issues that they do in the stage 4 space. But we've got to identify the patients who are eligible for adjuvant therapy in the first place. That gets to the nodal issue that we talked about and that was discussed extensively at one of the sessions this morning. Do a good job with the lymph node dissection. But then we got to get them to adjuvant therapy, right? And that's no offense to Dr. Shu, but that's increasingly on the surgeons, right, to sort of set that idea up and to sort of put the plug in their head to tell them that there might be lymph nodes, to tell them that that's going to be part of their journey. And particularly for the case that we showed, if you're going to start with a tumor that's about 4 centimeters, you know that somewhere along the way that patient has a high chance of lymph node disease, and they're probably going to need adjuvant of some form regardless. And this is the Violet trial. So this is Dr. Eric Lim's trial, and you've all probably seen it. And the trial was really set up to be VATS versus open. Remarkable, right, that the patient's randomized to do that, and that, in theory, should be a pretty incentivized patient population. If you think about who they are, they're saying, hey, maybe open surgery is better oncologically, so they've had lots of discussions about sort of the value of what we do and the long-term oncologic effects of these things. But yet you still see that of those eligible for adjuvant therapy, the eligible subset there on the second line, only about 50%, 46% in the open surgery arm were able to actually get there and get that adjuvant therapy in this group of motivated patients. Now, some of this may have been the sort of underwhelming enthusiasm for adjuvant chemotherapy, and I suspect it will be different to patients you can offer an adjuvant targeted therapy and a pill in particular. But I think it's interesting to see how we think about adjuvant and can we count on adjuvant. And this highlights the low rate of adjuvant uptake, but also you see that it's on here somewhere, adequate lymph node dissection, which again we spent some time talking about this morning, was only performed in 53% of cases. So maybe we're missing opportunities to first diagnose patients eligible for adjuvant therapy, but second, to actually deliver that adjuvant therapy to these patients. And you can see that of the patients in the Alchemist screening study, you can see the stage distribution there. I'm sorry, this is Alchemist. I missed that on the switch. So this is the patients who are eligible for adjuvant but didn't enroll to one of the arms. So again, a motivated patient population. So we're going to go back to the masterclass portion, and I think I'm turning it over to the master here to go through the data.
All right, thank you, Dr. Stiles. We have a few more people trickled in, so thanks everyone for joining us today. All right, so I'm starting with a polling question first. So, based on findings from Adora, adjuvant osimertinib should be recommended as the standard of care therapy for patients with 1, EGFR mutated stage 2 to 3A non-small cell lung cancer with or without adjuvant chemotherapy. 2, EGFR mutated stage 2 to 3A, but only with adjuvant chemotherapy. 3, EGFR mutated stage 1B to 3A with or without adjuvant chemotherapy. And then 4 is stage 1B to 3A, but only with adjuvant chemotherapy. And 5 is, these all look the same to me and I'm confused and I'm not sure is the answer.
Did you use the music, Dr. Shu?
I did not choose the music, but. All right, so it's kind of a 20% chose 2 to 3A with or without, and 45%, the majority of you chose 1B to 3A with or without. Okay, great. And then 10% said I'm not sure, so we're gonna try and talk about some of these things and explain what's happening with the data. So most of our time today is going to be talking about Adora, which was a big phase 3 double-blind study that was performed a few years ago. This looked at patients with completely resected stage 1B, 2, or 3A non-small cell lung cancer. And they could have had chemo or with or without adjuvant chemo, so they came to us afterwards. And they had to have an exon 19 or an L858R, so your classical EGFR mutations. And they had to have had a complete resection, negative margins, and they were stratified by their stage, the type of EGFR mutation, and race. And then they were randomized 1-to-1 to osimertinib 80 milligrams daily or placebo once daily. And this continued for 3 years. The primary endpoint was DFS, disease-free survival, in stage 2 to 3A patients. And the secondary endpoint was disease-free survival in the overall population. So this trial was, really an outstanding success here because we see that the DFS on the left, you see stage 2 to 3A disease, and the hazard ratio for this was 0.17. So on that Kaplan-Meier curve, you can see the curves really diverge in a way that we don't typically see. So the patients who were getting the osimertinib in the blue up top had a much lower chance of disease recurrence or death. So that hazard ratio of 0.17 means that there was an 83% reduction in risk of recurrence or death. And if you look on the right, that's for stage 1B to 3A, and it's similarly impressive. The hazard ratio there was 0.20, so an 80% reduction in the risk of disease recurrence or death. And I mean, numbers like this you see once in a blue moon, I would say. So, okay, so that was out, and now these numbers are kind of the most recent data cuts from ESMO 2022, and you can see that it's the DFS in stage 2 to 3A is still very impressive. The hazard ratio is 0.23, and this is at 50% maturity. And in the overall population, same type of thing with a hazard ratio of 0.27. So you can see that osimertinib arm really just does much better than that placebo arm. And I always like this, and I asked them to put this in for us because, a lot of times people ask, well, what does it tell us about adjuvant chemotherapy? And if we look at this subgroup analysis, really it's interesting because you see that kind of no matter what stage you are, whether or not you get adjuvant chemotherapy, the osimertinib arm is still better. It doesn't tell us that you should or shouldn't do chemotherapy. It just says no matter if you got chemotherapy or you didn't get chemotherapy, the osimertinib arm still does better. And that's if you're stage 1, you're stage 2, you're stage 3. You can see it's all favoring the osimertinib arm. And then when we look across subgroups, right, we see that OC was better than placebo and, just about down the line, right? So it didn't matter if you were male or female, young or old, if you were a smoker or never smoker, Asian, non-Asian, the stage, like we just talked about, the EGFR mutation. So typically we think of L858R patients as doing a little bit worse, and we can see maybe that there was some of that, but still they did better than with OC than with placebo. And again, with adjuvant chemotherapy. So if you got adjuvant or you didn't get adjuvant chemotherapy, you still benefited from osimertinib. When we look at the updated DFS by stage, we see the same type of thing for 1B for stage 2 and for stage 3A, that the hazard ratio of 0.44 for the 1B, of 0.33 for stage 2, and for stage 3A, a hazard ratio of 0.22, which is really, these are remarkable numbers for us. Okay, so you say, okay, well, what about the patients who do recur? Where are we seeing the disease recurrence? And I would say the most common first sites tend to be lung, lymph nodes, and CNS in the osimertinib arm, which you can see here in blue. And again, here in placebo, you can see a similar type of thing. But the tornado plot really shows us how tight the osimertinib side is compared to the placebo side. And this is really important because we know that lung cancer loves to go to the brain, and we also know that osimertinib has really good blood-brain barrier penetration. So one of the important secondary endpoints we said was CNS disease-free survival. And you can see here that the patients who got osimertinib had a lower risk of developing CNS mets, and that hazard ratio was 0.24. So we know that this is also benefiting our patients by hopefully preventing brain mets. All right, so you say to me, well, this all looks great, Dr. Shu, but is it really hard for these patients to take this drug for 3 years, and what is it costing them? So when we look at the AE profile, we can see that the most common thing with osimertinib is diarrhea, but most tend to be kind of low grade, and grade 3 to 4 is actually very low. The other things are paronychia, dry skin, so rash and diarrhea tend to be the most common things we tell patients, stomatitis as well. And kind of an important one is interstitial lung disease, which we see in a small percentage, and also some cardiac things, which we also see in a small percentage. Now, I guess, okay, so are these mostly manageable? And I would say yes, because you would see here that 13% of patients in the osimertinib arm had to discontinue treatment. So, I would say most patients are able to finish the 3 years. There are some patients who have to come off because of AE toxicity. So after 3 years of planned study treatment, overall, there was a 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, which gave us a DFS hazard ratio of 0.23, and that was in the stage 2 to 3A population. The median disease-free survival was 65.8 months in osimertinib arm and 29.9 months in the placebo arm. In the overall population, that still held, so when you added in those 1B patients, we could still see that there was a significant disease-free survival benefit. And again, it didn't matter whether or not the patients received adjuvant chemotherapy, they still saw benefit. So sometimes I'll tell patients, if they really can't tolerate the chemotherapy, sometimes I'll just cut out that chemo early and start them on the OC. And then importantly, we said osimertinib demonstrated a clinically meaningful improvement in CNS DFS. And again, the safety profile was consistent with kind of our known established safety profile, and patients are able to complete the course. So all of these data together really reinforce adjuvant OC as the standard of care for patients with EGFR mutated stage 1B to 3A non-small cell lung cancer after complete tumor resection, with or without adjuvant chemotherapy. And Dr. Stiles and I are really here today to kind of reinforce these with you, because we as medical oncologists won't necessarily see these patients unless you send them over our way. And this is kind of a big thing with everyone's been asking about OS data, and is it worth giving if there's only a DFS benefit and there's no OS benefit? There's a lot of debate in the medical oncology world, but we do know that Adora OS data will be presented this year at ASCO, so we're all really looking forward to seeing what those numbers look like. Okay, so after I discussed all of that, we're going to redo the polling question. And again, adjuvant OC should be recommended as a standard of care therapy for patients with 1, EGFR mutated stage 2 to 3A with or without adjuvant chemo, 2, stage 2 to 3A, but only with adjuvant chemo, 3, 1B to 3A with or without adjuvant chemo, 4, 1B to 3A, but only with adjuvant chemo, and 5, I'm not sure. And you're not allowed to choose 5 anymore, right?
Correct.
Okay, so, oh, look at that. 82% post chose that they were going to, with or without adjuvant chemotherapy. And 0% are no longer unsure. So I think you guys did a great job here. So yeah, I would say EGFR mutated stage 1B to 3A with or without adjuvant chemotherapy. And if in doubt, just send the patient to your friendly medical oncologist, and they can figure some of that part out. Okay, so with that, I'm going to turn it over back to Brendan. He's going to talk about some other trials looking at early stage non-small cell lung cancer.
Yeah, there's lots happening in this space, and I think you probably learned from the meeting. Lots of great talks yesterday about identifying patients at risk for recurrence. Heard a great talk from the JCOG authors about recurrence in that set. And then I admit I'm like blinded sometimes to stage 1. I always think that my patients are going to do great, and then you see the presentation of the CLGB data this morning, you see that 30% of these patients are recurring. It's really interesting and sort of humbling to think about that sometimes for me. So I was sort of a skeptic in the 1B space. It'll certainly be interesting to see what the overall survival data shows. Keep ASCO on your radar for sure. We've been talking a lot at this meeting about neoadjuvant therapy, and so obviously the question is there a role in the neoadjuvant space for this? And maybe that patient that Dr. Shu showed at the beginning with the sort of big tumor might be someone who we know that we don't want to put those patients on neoadjuvant immunotherapy because of lack of response. But what about a neoadjuvant targeted therapy approach? So this is a phase 3 trial that's already enrolling at stage 2 to 3B, resectable non-small cell lung cancer with the common EGFR mutations, stratified by stage and also by ethnicity. It's a double-blind trial, and the arms placebo plus chemotherapy, 3 cycles, osimertinib plus chemotherapy, 3 cycles, or just osimertinib alone. So I think it's well designed to answer a lot of important questions. Does chemo add a benefit to osimertinib? What kind of pathologic response rates will we see with osimertinib alone versus OC plus chemo? And you can see the endpoints are MPR and PCR, and then I think it's nice because adjuvant is the investigator choice, and I think that does allow for some real-world practice into it. And then we'll get EFS and OS eventually with that as well. So these are a couple of patients, and probably, this was actually from David Jones and Neil Chudgar, who now work with me, where they just described a couple cases in the literature. And I think there was a discussion about it yesterday. It's not standard, right, to give neoadjuvant osimertinib, but we can probably all think of a couple cases that we've thought maybe it's a good idea for and done it. And in this publication in JTCVS Techniques, they just sort of described sort of what kind of responses there were in some of these cases. I suspect we'll be asking all the same questions that we did about neoadjuvant immunotherapy. Does it make it harder? Does it take longer? Challenges like that. We heard a great talk yesterday about neoadjuvant alectinib, actually, that talked about some of the challenges there. Yeah. So Adora 2 gets to that sort of blind spot that I was talking about, the kind of patients that we heard about from the JCOG authors from Nasser Al-Turki this morning, the CLGB. the stage 1As, right? They're not eligible, so 1A2 or 1A3, the bigger tumors, after complete resection, pathology reviewed. And then they're going to be stratified by high risk or low risk, and again by race. And to sort of answer that question, does systemic therapy work with even earlier stage disease? And there's a lot of people out there wondering, are we pushing it too hard, and are we over-treating these patients? And obviously 3 years is a fairly long treatment duration for a drug from a patient perspective, but to me it sort of depends on the tolerability of the drug and on the side effects of the drug, which Dr. Shu will talk a little bit as we go. And interestingly, we had these great talks yesterday about how do we define high risk. It's a moving space, and it's probably going to be ultimately defined by ctDNA, is my guess, but we heard a lot about pathologic predictors. David Jones talked about his algorithm for high risk. But for the purposes of this study, it's invasive tumor size greater than 2 centimeters, lymphovascular invasion, and then greater than 20% micropapillary solid, these atypical subtypes that we talked about a little bit this morning. Low risk is obviously defined as the absence of any high risk factors. And the thought was that high risk will comprise about 60% of this cohort.
Dr. Stiles, before you move on,
Mm-hmm.
we got a question that said, how would you treat a stage 1A resectable EGFR positive patient? So would something like this maybe a good trial for a patient like that?
Yeah, it's perfect, and that's great, actually. Somebody had just actually asked that question, too. So what would you do? I would put these patients in a trial, and I think that's the way to go. I think it's a great conversation to have with patients. I find these patients to be typically more motivated. They sort of feel like they've got an EGFR, they know why they got their cancer, they can blame it on something, they want to at least have a conversation about it.
Yep,
I have to say I'm guilty of not sending 1As to the oncologist, but maybe it's something I have to think about.
Have that recorded.
I'll put in a plug for LEADER, sponsored by the Lung Cancer Research Foundation. An umbrella trial really to try to capture all drivers, and really it's looking at testing really, and I think that this will help sort of think about how we think about testing, but it does have a lot of trials tagged on to these specific therapies, and again, looking at major and complete path response rates. EGFR is obviously very prevalent and something that we see all the time, and again, at Cornell, we did a study just looking at our patients with routine testing. It was over a third of our patients had EGFR mutations. And so, you don't find it unless you look. And so I think that this really emphasizes that the more rare molecular alterations, really, we're not going to see at single center. So it's got to be a big sort of trial like this where we sort of pool our resources together and really get surgeons there sort of leading the charge. So optimizing these, this is back to Dr. Shu, I believe. Is that right?
Yeah, we're in our cases. Okay. So just one quick thing, which is that Dr. Stiles said he was sometimes not sending, he was a little guilty of not sending his EGFR patients to medical oncology, and that's recorded for posterity. But we got another question on there that said, when do we send patients to see medical oncologists, or when do we as surgeons kind of discuss osimertinib with the patient? And I mean, I think that's it's a great question. EGFR is getting more and more kind of diverse. There are some EGFR mutations that don't actually respond to osimertinib. So it can be a little bit tricky if you just see EGFR and say you're definitely getting osimertinib, but I think it's always a good thing to refer to your medical oncologist, even if it's early stage, very early stage. Maybe they can put them on like Adora 2 or something like that.
But it must help you if the surgeons talk to the patients a little bit about it first, right? And
Absolutely.
Sets the stage.
It's always helpful if they say, this is why we're sending you to see a medical oncologist. There may be other treatment options for you. So now that we're going to return, now that we're armed with all this info, we're going to return to this case. And so for those of you who weren't here originally, she's 64-year-old, she's a never smoker, and she presented with COVID-19. And a chest CT showed a 3.4 centimeter left upper lobe mass. The PET scan demonstrated, and she has a 3.0 centimeter solid appearing mass. Its SUV is 5.3. Pleura is normal, no mediastinal or hilar lymph nodes, and no sign of distant disease. So here I'm going to ask you, Dr. Stiles, is this someone you would do mediastinal staging on, and why or why not?
Well, it's a great, I would definitely do it now that I knew from the previous slides that it's positive.
Well, you have to pretend you don't know yet.
Yeah, it's some of you weren't here. I went through the result in this, and it really just shows the inadequacy sometimes of clinical stage. And it's a central lesion no bigger than 2 centimeters, and so I think a lot of people in the room think that those at least deserve a really good EBUS. If mediastinoscopy is not used as frequently, but I would certainly do or have one of my interventional pulmonologists do an EBUS and work really hard. I think the other point about that, an EBUS doesn't mean just kind of look and don't really do anything. It means really get in there and biopsy, try to even go out and get some N1 nodes, because I think those are increasingly important for how we think about the journey of these patients. So central tumor, relatively high SUV, reasonable 15-20% at least risk of microscopic nodal disease.
Okay, so this patient did go for EBUS, but the interventional pulmonologist didn't see anything suspicious, so did not do any additional biopsies. So you would try and maybe...
So that was more like a regular pulmonologist and not an intervention-inclined pulmonologist. Well, I think then if they've made a good effort, I wouldn't put the patient through another procedure. I think it's reasonable to proceed with upfront surgery in this setting if you're not suspicious for nodal disease.
Okay, so the patient, the only biopsy she ends up undergoing is the transbronchial left upper lobe mass, and it showed invasive lung adenocarcinoma. So, knowing what you know, EBUS was negative, 3.4 centimeter mass. What would you guys like to do? 1, take her to the OR for a surgical resection. 2 is refer her to medical oncology to discuss neoadjuvant treatment. 3 is to send for molecular testing. And 4, I am not sure.
We have a much bigger sample size this time. We'll
Yes.
see what we get. Do you guys get, at Columbia, do you get reflex testing on the biopsy sample itself?
Yeah, so we do reflex testing. And I think we'll talk about that in a second because, oh, look, so some of you weren't here when we first started, but 100% of the surgeons said that they were going to take the patient directly to the OR, which is not the wrong answer, right, Brendan? But some of you already know the ending of this case, so it's a little bit changed. 56% now say they wouldn't, or 56% said they'll take her to the OR, and 41% said that they're going to send her for molecular testing. And probably one person here said refer to medical oncology. So we actually do reflexive testing on all of our lung adenocarcinomas. That means we do EGFR, but we also do some of the other major markers. And I think that that's more and more important nowadays with all of these new targets, with all of these new indications. Do you guys also?
We do, yeah, but how many people in the room, just maybe raise your hands, do reflexive testing on the biopsy specimen? Handful. We and many other institutions have had this struggle, like when do you do it? Do you wait? If they think they're going to get more, do you wait and save it and all that stuff? So it definitely comes into play as we think about how to manage these patients perioperatively.
Yeah. So for her, actually, she had the NGS panel revealed an EGFR exon 19 deletion. Okay, so now we know she has a 3.4 centimeter mass, and she has an exon 19 deletion, but no suspicious nodes, mediastinal or hilar lymph nodes. So now what do we do? Does that change your management? Do we still take her to the OR? Do we refer her to med-onc to discuss neoadjuvant treatment, or I am not sure? Oh, more people want to take her to the OR now. Okay. So we have about 80% of you want to take her straight to the OR, 20% to discuss neoadjuvant treatment, and 4% said, I am not sure.
This is the horrible thing, right, as surgeons, when you've got them clinically staged is one thing, and then the path is completely opposite, right? It's a tough conversation to have with the patients. It's a bigger tumor right now. It's over 4 centimeters, end-2 disease. So this is...
You're stealing my thunder. I
This
didn't
is
even...
tough. But you don't have to have the first conversation. We have to have the first conversation. I told you you're going to be stage 1, everything's going to be great, and then you get this horrible disease.
Yes, it's true. So anyway, as most of you said, the surgeon decided to take her straight to the OR, small-ish tumor, no obvious nodal disease. We knew she had an EGFR exon 19 deletion, but honestly, she probably wouldn't have even qualified for something like Adora.
Right.
So she goes straight to the OR, and the surgeon performs a left VATS upper lobe, and there's a 4.4 centimeter invasive adenocarcinoma, moderately differentiated, extending into the visceral pleura, and there were multiple lymph nodes that were involved. There were 2 level 5s, 1 level 7, and 2 bronchial. So she was ultimately staged as a PT2B N2, and Dr. Stiles is right. I mean, it's hard for the surgeon to explain to the patient, I think, that now she's upstaged to a stage 3A.
But in some ways, if you've had that conversation about staging that there might be lymph nodes there beforehand, then it's not quite as bad when you tell them here.
Yeah.
So I tend to tell all my patients, and probably almost all of you in the room do, right? That we're going to take you to that room, we're going to take this out, we're going to take out some lymph nodes. There's an X% chance you might have lymph node disease. And so they really sort of hang on that idea, like, well, how are the lymph nodes? What happened with the lymph nodes? And it's not as sort of disheartening when all of a sudden you tell them about pathology like this.
Yeah, agreed. Totally agree. So now what do you guys want to do? So 1 is adjuvant chemotherapy. 2 is referral to radiation oncology for postoperative RT. 3 is osimertinib for 3 years. 4 is atezolizumab for a year. 5 is observation, and 6 is I'm not sure. And there may be more than one correct answer, so we're not judging on which correct answer you guys choose.
Every time the medical oncologist says they're not judging, they're judging.
Note that was also recorded for posterity's sake. Okay, so the question was whether or not the margins for this case. The question was some more detail on the pathology, and the margins were negative, and there were many other lymph nodes taken as well. Those were the only ones that were positive, and.
Were they taken entirely, or were they like cancer rupture?
The Columbia surgeons did an excellent job on the lymph node dissection. So let's assume for the purposes of this that they did an extensive lymph node dissection, they went above, and nothing else was positive, I think.
Yes.
Yes.
Correct. Okay, so now some of us are recommending adjuvant chemo, a few of us are recommending post-op RT, which is more or less fallen out of favor for N2 disease nowadays. A lot of us are recommending osimertinib for 3 years, and some of us recommended atezo for a year previously, which some of them may have gone to the perioperative immunotherapy talk from a few days ago. And 3% now say atezolizumab for a year. So I just want to point out that atezolizumab and immunotherapy in general, I think in the perioperative space is getting more and more important as well. That's not really the focus of today's talk, but we are finding chemo and immunotherapy together in the preoperative setting is really helpful for patients. For our EGFR patients who tend to be never smokers, we really don't give immunotherapy to them. So this patient was referred to medical oncology. I saw her. Given that she was now upstaged to 3A, I did recommend that she get chemotherapy. She actually tolerated all 4 cycles of adjuvant cisplatin and pemetrexed really well. She's now undergoing 3 years of adjuvant osimertinib, and she's tolerated it really well. I would say her only issues tend to be a little bit of dry nails, and otherwise really no symptoms. She swims like a mile every day, so she's doing very well.
Do you only skip the chemo in frail patients?
So I skip the chemo in, like, if they're stage 1B, or even if they're mostly in the 1Bs, I'll offer them just adjuvant OC. In the patients who are stage 2, we kind of talk about it, and the frail patients, I kind of just skip it. And the patients who are very motivated, I do give it. And in the stage 3s, I still offer them chemotherapy. I think chemotherapy is still proven, and there's nothing so far to say that, that not giving it is just as good. So yeah, but it's a discussion that we have with the patients. So I guess as a surgeon, if you say to the patient, you could get adjuvant OC, don't tell them that they're not going to get adjuvant chemo.
Absolutely.
Okay. I have another case, and then Dr. Stiles has a case. So this one's slightly different. So now we're talking about a 71-year-old gentleman, good health, and now we're saying this is a 5.8 centimeter mass, right upper lobe mass, abutting the mediastinal pleura, and a 2.5 centimeter satellite lesion, and he has some right hilar adenopathy, and he's staged as a 3A clinically, T3N1. Okay, so what do you guys want to do here? 1, perform mediastinal staging with EBUS. 2, send him to interventional radiology for biopsy. 3, take him straight to the OR, or 4, I am not sure.
Do the medical oncologists say I'm not sure for a lot of cases? Because surgeons almost never say that.
Yeah, 0% said I'm not
Yeah.
sure. I say I'm not sure a fair amount. Okay, so the majority of you said mediastinal staging, so I think that's good. Some of us said IR for biopsy, and a few of you want to take him straight to the OR. What do you think, Dr. Stiles? Which one would you have chosen?
Definitely mediastinal staging with the EBUS. I mean, there's clinical nodal disease, and I think this is a really critical one to stage the mediastinum, make sure that there's not N3 disease. I think we don't do as much as we used to, but I think that's important too. I think, maybe, I guess the people who chose interventional radiology maybe thought it's sort of peripheral, maybe hard for their pulmonologist to get to. So it does, if you got negative nodes, then you might have to go back and do something again, but I think this one with obvious clinical nodal disease should certainly start with the EBUS.
Okay. So he gets an EBUS. Let's see if we can. Yep. So it's negative at 4R, 4L, and 7. 11R is consistent with adenocarcinoma, positive for CK7, CDX2, negative for TTF1. And no molecular PD-1 was performed at that time. But then this patient was seen at an outside hospital, they didn't have reflexive testing.
Right.
But the surgeon actually said, why don't you go see my colleague, Dr. Shu? And I saw him, we sent him for molecular testing first because he was this never smoker, and it revealed an EGFR L858R mutation. And now, what would you recommend for this patient? Now that we know he has an EGFR L858R, does that change your management? So 1, do we still send them straight to the OR? We can discuss adjuvant osimertinib afterwards. Do 2, consider neoadjuvant chemo off trial? Or 3, consider neoadjuvant osimertinib on trial? Or 4, I am not sure. And Brendan, I do want to point out that, one of the best things about my job is working with surgeons. And like you see in this patient, the surgeon he sent the patient to see me. To discuss, whatever, see what targetable mutations the patient might have. So it's nice to have a good relationship with your medical oncologist.
For sure.
So about a fifth of you said send them straight to the OR and discuss adjuvant OC. That's not a wrong answer. Consider neoadjuvant chemo off trial. A few of you consider neoadjuvant OC on a trial. Maybe about 2/3 of you. And I'm not sure about 7%. And so...
This one's pretty good. I mean, I think you can make an argument for all 3 of those answers, right?
Yeah.
If you go back for a second, right? And you're going to talk about what you did, but I think you could say, hey, adjuvant, they get the benefit stage 3. This is kind of a bulky-ish, more alarming stage 3, and so I like the idea of giving them neoadjuvant.
Yep.
I think you could say give them the 3 cycles of neoadjuvant chemotherapy, because then they won't need it in the adjuvant and go to that.
Yep.
And then certainly if you have a trial available, I think that's a great option for this patient.
Yep.
But I think all 3 are defensible positions.
I agree. And not everyone will have access to a trial, so I certainly think that the other options are good options. But the point is, I think that the surgeon, sent him to me, and then we had a discussion about what we
Absolutely.
wanted to do. And so this patient was actually enrolled in Adora, which we do have at Columbia, and he was randomized to neoadjuvant osimertinib, 80 milligrams daily. And you can see after 9 weeks, the mass shrunk significantly. The satellite lesion also decreased in size and avidity, and there was no significant change in the hilar lymphadenopathy. So he ended up going for surgery after the 9 weeks of treatment. He had a right VATS, right upper lobe, thoracic lymphadenectomy. The surgeon did note there was some fibrosis from the induction therapy within the hilum, but the patient tolerated it very well, and he had some post-op atrial fibrillation. And ultimately, the pathology showed a 3.5 centimeter tumor, negative margins, with 1 hilar node affected out of 18 nodes examined. And the patient is now on adjuvant osimertinib. So Adora does neoadjuvant and then adjuvant. Okay, so after listening to our discussion and the outcome, does this change any of your management? Do you still send them straight to the OR and then discuss adjuvant OC? Do you consider neoadjuvant chemo off trial? Do you consider neoadjuvant OC on a trial? Or I'm not sure. And like Brendan said, these are all reasonable options. Oh, look, everyone wants to send for a trial.
Awesome.
No, that's great. I think all of these, again, like we discussed, are all reasonable options. But certainly, I think we're all interested in knowing whether or not neoadjuvant OC is going to be beneficial to patients. Okay, so I now turn it over to Dr. Stiles for his.
So I'm going to show a case too, and some of you may have seen this case before, but I think it illustrates a couple good points for me. So 52-year-old Hispanic female, never smoker, really had a huge delay in her workup. It was having sort of cough and having pneumonias, and she had, you can see an endobronchial lesion. Everybody thought she had pneumonia, but was sort of regularly hemoptysizing and went too long without getting diagnosed. Subsequently found to have, and you'll see some of the pictures, difficult to tell the size of the actual tumor, but 9.6 in one dimension. Mass, you see this is the bronch that shows the left lower lobe bronchus completely obstructed. And she had a big bulky level 7 node that was positive by EBUS and was found also to have an L858R mutation. So for me, looking at this and thinking about it, you can see how it was completely blocking that lobe, so she's not using the lobe. And pretty bulky adenopathy. Brain MRI, which I think should be indicated in all these patients, was negative. And so then the question was, let me see what to do next, but I'll tell you, well, let's see what you guys say. And then we'll talk about sort of my thinking. I'd love to hear other people just how they would think about a case like this. But so how would we do this patient? We could give neoadjuvant chemotherapy. She's got really sort of bulky disease, then surgery adjuvant OC, chemoradiation followed by osimertinib. Chemoradiation followed by Durva, Pacific protocol. They allowed EGFR patients to be in that group. Or off-label neoadjuvant osimertinib and reassess. Or I'm not sure. This one I sneakily put on Twitter as a poll, and you can see how I gave 2 chemoradiation choices to make surgery hopefully look better against 2 arms of radiation. My goal, though, was actually trying to avoid a chemoradiation approach. And that's the mindset, a big tumor, bulky, level 7, I think often would be straight to chemoradiation. But this lady, she's probably our thinking is that she's not going to benefit from Durva at the end in the Pacific, right? Mm-hmm. So we gave her, we were a little bit worried about her advanced disease, so we just gave her osimertinib, which we think would be standard of care in the stage 4 setting. We targeted 8 weeks, but she ended up going out to 10 weeks, and she tolerated it great. She had a great clinical response on imaging, and you can see the tumor shrunk quite a bit. And in this, I'm interested to hear what people think. The endobronchial disease went down significantly. And so that takes it away from being a sleeve, takes it away from being a pneumonectomy potentially, I think, to being a lobectomy. And the question is, how do we know what was disease there? Is there microscopic disease there? How do we think about that? But so we took her to the OR and just did a standard VATS lobe, and it was relatively straightforward. There was definitely some stickiness around the big node, and that was probably the harder part of the case. But she did great, went home on post-op day 3. Interesting questions about response rates in these patients, and is it tumor static? Are we going to see the path response rates that we see with immunotherapy? She had a great response. She only had 0.9 centimeters of viable tumor, so she actually classified as a major pathologic response. She had one lymph node that still had positivity, just 10% viable tumor. So her path stage was T2A, N2. So then what do you do? So she's already gotten 10 weeks of OC, and what would you like to do here? We could give radiation, and some might argue bulky level 7 disease. She had persistent disease. Let's give some postoperative radiation therapy. Should she go the immunotherapy route? She's got resected disease, chemotherapy followed by atezo. Should she get chemotherapy at all, or should she get chemo then back on the OC, or should she just get osimertinib only? Or I'm not sure. And then we'll ask Dr. Shu what she would do here. Hopefully she won't say atezo. No offense to that. Yeah, so it looks like most people opted for chemotherapy followed by osimertinib. Some people wanted to give radiation therapy and some osimertinib only. Certainly the patients are often interested in the osimertinib only side, but with this bulky disease and her young age, we thought that we offered her chemotherapy and osimertinib.
That would be my vote as well. Absolutely.
Awesome. So are we up to the Q&A?
Yeah, so I think we have a few minutes left. We have a few questions from online, but we will also be happy to take questions from the mic.
Oh, Dr. Spicer.
What would you have done if you had downstage her to a stage 1A and her baseline stage was a stage 3 or maybe even a 3B there? Would you still give the chemo?
I would, yeah, I think so. The initial stage really speaks towards the prognosis, I think. So I would still favor giving the chemotherapy followed by the osimertinib.
What do you guys think? Anybody in the room with a lot of experience operating after TKIs? Any of our Japanese colleagues? Anybody in the room? The question is, how hard is it after neoadjuvant TKI? I don't know that I've done enough to really get the answer to that. A lot of others speak to others that I have seen were often after patients who got extended therapy and then were taking out some sort of oligopersistent thing.
Well, our surgeon did say that there was significant fibrosis, but I guess the point is that you can see fibrosis with any neoadjuvant treatment, whether it's chemo, whether it's immunotherapy, whether it's TKI. I think that's something that...
So here's a question. This is a good one for how surgeons think, right? So what if you have no trials at your institution and you risk losing the patient for referring elsewhere for the trial? Right, and surgeons will get judged by our volume and by our outcomes. So what do you think, Kathy? Dr. Shu?
I think it's a good question.
She tries to steal patients from us all the time and say, oh, we've got this Adora thing. Come over here.
I always tell patients that a trial does not mean that it's better than standard of care, and I think that that's really important for them to know, that this is why it's a trial. If I knew it were obviously better, then it would be the standard of care. So I think I really try and demonstrate equipoise, and I normally would say, if you feel more comfortable with Dr. Stiles, and then just go back to him, of course, right? And a trial is not the only answer.
Yeah, I think that's a good thing too. But I think you can make a reasonable argument for, it's easier with the earlier stages where you could go for adjuvant, right? And then you don't need a trial for that.
That's true.
But I think the neoadjuvant space is definitely tougher. So here's a good question: the stage 1-2, or just saying EGFR patient strongly positive for PD-L1. What is the role for immunotherapy there, Dr. Shu?
Okay, that's a good question. So, for the EGFR positive patients, they tend to be never smokers. For the never smokers, I really don't give them immunotherapy. It doesn't really benefit them. So even though sometimes you might see high PD-L1 scores on those EGFR mutated patients, don't get tricked by that. I would definitely still do the osimertinib and not the immunotherapy. But I do think that immunotherapy is in the preoperative space definitely has its place, and many of you might have heard Dr. Spicer talk about this the other day. And so, but not for your EGFR patients.
There's some questions about radiation therapy, and obviously you have a lot of experience with chemoradiation patients and sort of getting into treatment afterwards. Do you any issues with radiation therapy and osimertinib for you?
You know, there is a trial, Laura, ongoing that's looking at chemo RT followed by osimertinib, right? And because I think we all feel that the Pacific regimen is not great for EGFR mutated patients. So I'm excited to see how that will pan out. I mean, I think we can all agree that there are some patients with very bulky N2 disease who just aren't going to be good surgical candidates. And for those patients, you know, chemoradiation might make a lot of sense.
Somebody asked about how often EBUS is insufficient for molecular testing, and I think probably too often. I think
That's a good question.
I was on a panel and heard the group from Penn has done a lot about this, and they talk a lot about, you know, quantity not sufficient. And maybe 20-30% of the time, it sounds like everybody thinks that their rates are higher, but I still think that that's a big problem.
Yeah, I would say that I often come across insufficient material on an EBUS, which is frustrating, I think, for all of us because the surgeon wants to get the patient booked and doesn't want to do another biopsy to get the molecular testing resulted.
So how do you deal with that? And that is the patient too, right? They want to get in. You want to put them through another invasive procedure. Maybe it's going to be insufficient. So how do you handle those conversations?
I just had that exact case last week, and both the surgeon and the patient said that they wanted to go straight to surgery. The patient was a never smoker. They just didn't want to undergo another procedure, so they went to surgery. And I'm seeing him on Thursday, so I'm not sure yet. But I think that's the question about pathology and kind of tissue and how do we be good stewards for tissue since there's limited tissue, I think is a really important one. And it's something that we're continuing to explore. But if you're able to get reflexive testing, I think that's really important. If not, then really try and send to your medical oncologist if possible.
Yes, please.
Yeah, I'm Dr. Galati. So if you look at the Adora trial, and you're starting to see, especially the extended out to 72 months, you start to see convergence of the curve. So does that mean we need to be giving the Adora for longer? I mean, and what does it say about the mechanism of action of the Adora?
That's a great question. It was here. Somebody said, "What's next after osimertinib?" So I was going to actually ask Dr. Shu the same question. It's a great question. You know, at that drop off after 3 years, what are you doing there?
You see sort of an inflection point after the 3 years.
Yeah, I mean, I think we'll have a lot of answers after ASCO, which will tell us about the overall survival benefit. I think, no one really wants to kind of indefinitely extend osimertinib, but if we see an OS benefit at 3 years, I think that's probably where we're going to stop. I do stop patients sometimes if they're unable to tolerate the drug, but.
And what % of patients is that, do you think, that are unable to tolerate? Pretty rare, right?
Yeah, I mean, I think Adora was like, they said 10% had to discontinue. I think I probably discontinue about 10 to 15%. I don't know. None of us really know, but I think once we have those OS numbers, we'll be able to make a more educated decision.
So does that mean that the Adora is just suppressing the tumor and it's sitting there waiting to strike again?
I think that's the question we're all asking. I don't think so. I'm a believer. I mean, you see those hazard ratios, and I just think that there's got to be some OS benefit. But certainly with time, as we continue to monitor these people for OS, we can have more information on that.
Thanks.
Great questions. Thanks.
Yeah, very good question. Anyone else before you guys?
Last chance to ask Dr. Shu, who came all the way here. Yes.
Hi there. My name is Ario Safarzadeh. I'm a thoracic surgeon in Mission Viejo. If you're doing adjuvant therapy without chemotherapy, is there a shorter duration that you can wait before initiating therapy, or how long do you typically wait when you're doing chemo with adjuvant versus just with OSI versus just osimertinib alone?
I mean, I have to say nowadays with you guys doing minimally invasive surgery, robotic surgery, I mean, I'm generally able to start patients on chemotherapy within 4 weeks. And so OC, I kind of do the same thing. If they're not getting chemotherapy, if they are getting chemotherapy, I try and start the osimertinib right after the chemo. Like I give them a couple weeks off, but generally not. They don't need much more than that.
And Dr. Shu, I forgot, but what's the wait period in neo-Adora that you're supposed to wait before going to the OR?
I don't know.
You can often keep the TKI going right up to the OR, though.
Yeah, I can't. I think there's a short pause though.
All right, well, thanks everybody for coming.
Yeah.
Thanks, Dr. Shu, for
Thank you.
coming and sharing your knowledge.
And remember
with us.
to send your patients to your friendly medical oncologist, and we love working with you guys. It's truly like one of the best parts of my job.
Great, and if everybody could fill out their surveys too, that would be awesome if you had a chance. All right.